All right. Well, thank you for attending today. I know not everybody's able to get away at lunchtime, so this will be posted. The recording will be posted for future viewers. Um, so I'm Carla Shamblen. I'm the Director of Clinical Education for the PA program that's in Phoenix now with Creighton, and just want to kind of take you through a little bit about our program, how it might be a little bit different from the Omaha PA program that's been in existence for several years now. And even different from maybe the School of Medicine's medical education program that's had students here for 10 years in the Phoenix area. So, oops, not sure. Let's see if I can advance my slides. There we go. So as far as learning objectives, really, again, just kind of going through a little bit about our programs, what the rotations are like in terms of length, what we're looking to get out of our clinical rotations, what our students are able to do on rotation, or what the expectation is of students on rotation, as well as for clinical preceptors, kind of what it is that we're asking you to do in terms of your time in teaching and supervision of our students. So I want to start, this is one of the standards. So we have an accrediting body called ARC-PA. This is their most recent edition of the standards, the 5th edition. And this is what they say regarding our supervised clinical practice experiences, sometimes called SCIPPs. We call them rotations. But our students have to be able to see patients for preventative care, emergent care, acute and chronic problems. They have to see patients across the lifespan. For women's health, they need to see patients for prenatal care and gynecologic care. And then for surgery or surgical management, it needs to be preoperative, intraoperative, and postoperative care type encounters. And then lastly, they need to see patients for both behavioral or mental health conditions. And these kind of requirements do not have to be within every single rotation. It has to be it can be across the rotations within the program, but ultimately by the time the students finish our program, they must be able to have seen these types of patients and encounters in these settings. So we call them, like I said, we call them clinical rotations versus maybe like a clerkship that you might be familiar with as far as medical students. But what we're looking for is that students are engaged in patient assessment. So, you know, not just taking a history or just performing physical exam, but also kind of arriving at, you know, what could be going on with the patient, developing that differential and primary or presumptive diagnosis, and then being involved in the patient care decision-making in terms of management. So really, as a novice student in their first rotation, they probably will not even be getting to that point. You may be lucky to get a differential out of them, but certainly by the end of the rotation, or you know, within a couple of rotations on their clinical phase, we would expect that they're starting to have some of this critical thinking going on, and from a perspective of a provider, kind of thinking about what they would do with a patient from beginning to end. So our curriculum, we have 12 months of didactic phase. Our first cohort just started in August of this year, and they will be in their didactic phase until September of 24. At that point, they'll transition to the clinical phase, and for us, that's a 16-month phase. So in total, our program length is 28 months. Every program's a little bit different. The average is 24 to 27. But our clinical phase starts in September, and then it goes for a year and through the following December. So for this cohort, they will graduate in December of 2025. We have 10 rotations, and they're all the same length. They're all 6 weeks in length. We have a family practice rotation. We have an internal medicine rotation that has more of an ambulatory focus. So it could be an all outpatient rotation. It could be a mix of outpatient and inpatient. But if you look at the learning outcomes, they're more of an ambulatory focus. We have a women's health rotation, again, prenatal and gynecologic care, but no labor and delivery is required. Emergency medicine, surgery, psychiatry, pediatrics, and then our program has developed a required, what we call a selective rotation. I'll talk about what that means. And then the students will have 2 elective rotations at the very end of their clinical phase. So these first, we call these core rotations, family medicine through the pediatrics. and the selective will all be in that first calendar year of their clinical phase. It'll be in varying orders depending on you know, how many rotations we have in a certain area during a rotation block. But for the most part, they're all going to have their core rotations before moving into their electives right before graduation. So those last two, the elective rotation 1 and 2, are blocks 9 and 10, and those are the final 12 weeks before they graduate in December. So again, these core rotations are ones that are required by our accrediting body, and then our selective rotation is a rotation that is going to expose the student to care of the patient in the hospital setting. So it could be really in any medical specialty, and it could be an all inpatient rotation, or it might be a combination of some outpatient and inpatient. But really what we're kind of wanting them to get exposed to is, you know, admitting a patient, seeing a patient day to day and doing a hospital note, creating orders for things like IV fluids and oxygen, and discharge planning when the patient's ready to be discharged from the hospital. So that's the kind of exposure we want on this particular rotation. And then elective rotations can be really any medical specialty or subspecialty. And that's where we really try to take into account what the student's interest is, maybe where they want to get some additional experience, maybe an area of, you know, specialty that they know they want to go into, and try to find that for them. So just some special considerations about our program. So although we have these very you know, specialized type of rotations, our students are being trained as primary care PAs. We want them to be able to go after our program and feel comfortable working in a family practice setting, pediatrics, internal medicine, or ER urgent care, where they're seeing kind of a smattering of different things, and knowing not necessarily what the specialist would do, but when do they need to refer to the specialist? What would they tell their patient as far as, you know, things to expect when they go see that specialist or have that surgery? So really trying to get them to understand just the general primary care of patients. For our women's health rotations, we do want them to see patients for preventative care, prenatal care, and family planning, so contraceptive counseling, as well as for gynecologic care. But they're not required to be actively participating in labor and delivery. We do certainly teach them in the didactic phase about normal labor, normal delivery, and the complications of labor and delivery. But it's not required that on the rotation they're actively participating in deliveries. Our surgery rotations can be in surgical specialties, but as of right now, the national end of rotation exam that we will give the students is focused on general surgery concepts and conditions. That is changing. So next year, our association is putting out a second surgery rotation, end of rotation exam. And that rotation exam will have a little bit more broader scope in terms of breast surgery, plastic surgery, some other things, not so focused on general like intra-abdominal type surgeries. Students must not substitute for clinical or administrative staff. So again, we have a very shortened, abbreviated duration for our program. We're wanting to make sure that students are out there and starting to think and act like a clinician. So certainly we don't mind them helping in these things, you know, charting in the EMR or assisting with bringing, you know, patients back and getting vitals, but that should not be their main role when they're on rotation. We really want them managing the patients, seeing as much and evaluating as much, as well as participating in procedures. So who can be a preceptor? We allow our students to be precepted by not only physicians and PAs, but also nurse practitioners and certified nurse midwives. Physicians do need to be board certified in the area of instruction that they're precepting the student in. And then PAs need to be NCCPA or nationally certified. All providers then need to be licensed in the state of Arizona or be a federal employee where they're licensed in another state, but they do carry an active license without restriction. So as far as physicians, again, it's really important that they be board certified in the area of instruction. So if they're doing an internal medicine rotation, they should be precepted by a physician who is board certified in internal medicine. The only way that we can kind of justify to our accrediting body not placing a student with somebody who's board certified would be that we've exhausted all other options within a reasonable distance from campus and with effort to show that we don't have that kind of provider available to precept, which is not really the case here in the greater Phoenix area. We have a lot of capable board certified physicians, but we can also use PAs and NPs, as I said, or nurse midwives. Again, for nurse practitioners, they need to be certified in the area of instruction. So if they are doing a psych behavioral medicine rotation under a nurse practitioner, they would need to have their license and certification stating that they do that particular area of medicine, behavioral health. We do require a year of experience for PAs and NPs or DNPs as primary preceptors. We want to make sure that they obviously are comfortable in their own practice wherever they may be. So 1 year of experience, and then residents and board eligible physicians can certainly help with training our students. We just try not to or do not tend to identify them as kind of the primary preceptor of record. So if they're working alongside these providers, that's fine. But again, we need to have them be board certified. And then a faculty appointment with Creighton is not a requirement to precept our students. It is something that we offer as a benefit to preceptors, whether they be PAs, NPs, or physicians, but it's not a requirement. So I like this quote because I think it really kind of solidifies, what it is to be on a clinical rotation and how much it means to the student, the learner, to involve them in the care of patients on rotations. So as far as the expectations of preceptors, we don't have many. It's really not that burdensome to take on a student. We're asking that you kind of be aware of what they need to see on the rotation. So by looking at the syllabus and looking at the learning outcomes, you can kind of see the objectives and what types of patient encounters we're looking for on that rotation, kind of the depth of the type of experience that they need. That you promote active participation and provide instruction. That doesn't need to be teaching after every patient encounter or even during the visit, but certainly being available to answer questions of the student, maybe making time with them ahead and discussing that every day at lunch or once a week we'll talk about certain patient cases that maybe you found difficult or interesting. Providing positive and timely constructive feedback. It's really important, I think, not only to provide students with things they can improve upon, but also what they're doing well. I think that really helps to develop their confidence as a provider. It also reinforces what they should continue to keep doing, because as a student, sometimes they don't know if what they're doing, if it's right or wrong or best practice or ideal for you as the preceptor. And so kind of relaying to them positive and constructive feedback regularly is important. And sometimes this is accomplished, very casually throughout the day or week by week. But then we also have a formal way to do this. So we have a mid and end of rotation evaluation that we ask you to complete on each student. And then providing adequate supervision. So, kind of recognizing where the learner is in terms of their capabilities and their knowledge and their experience, and then making sure that you're providing adequate supervision to that student. For some of the student responsibilities or their capabilities, we ask that they work the preceptor's schedule. So this, it may be if your schedule is Monday through Friday, 8 to 5, 9 to 5, that's what they would work. But also if you have weekend hours or overnight shifts, or maybe you work 4 times a week, or you have night call or weekend call, certainly we would ask that you incorporate the student into that schedule of yours, however that looks. We want them to participate in clinical care, so patient interactions, and that can include things like calling back patients with abnormal results, or giving them patient education and spending extra time, making sure the patient understands everything that's going on that day, being involved in clinical procedures in the office. If there are rounds or conferences that you're attending or that you want the students to attend, we would encourage that you have them participate in those as well. Sometimes providers like to have students present a case presentation, maybe to their group or just to them. This is a great way to kind of get used to that ground rounds type feeling and what it means to present to your peers. So that can be a great way to incorporate the student. And then written medical documentation. So whether that be in the EMR or potentially writing up a SOAP note on a patient case and having you review it. All of these things they're not requirements necessarily, they're just things the students can do. Certainly if you have other assignments that you want to assign or things that you think would be beneficial, we encourage that as well. We kind of give you free rein. There's no prescriptiveness to the rotations, and there's no didactic sessions. So we as the program are fully kind of turning the students over to you for the 6 weeks. So however you want to arrange that, or maybe it's purely just patient encounters. They come to the clinic every day and that's fine. But we don't have any regimented scheduled didactic sessions for students. As far as attendance on rotation, we do ask that students be there daily as requested as the schedule of their preceptor. So their arrival departure time is dependent on you or the site. We do expect them to obtain at least 40 hours a week of patient care. And then in addition, if there's other, nights or on-call hours associated with that 40 hours, that would be above and beyond. We ask that you as the preceptor help to limit their time to 60 hours a week. Obviously, they do have other coinciding courses going on at this time and need preparation and time to study for their end of rotation exam. And so 60 hours a week or 16 hours of continuous time on task in a 24-hour period is kind of what we've decided as a program to be acceptable or appropriate. And then allowing students at least 1 day off in 7. We have some built-in days that we excuse the students from rotation regardless of your schedule or maybe the hospital. And so those would be noted in our preceptor handbook, but essentially they're the same observed university holidays that they get during the didactic phase as well. And part of us the reason for allowing those excused holidays or time off is because we allow a very few number of excused days during the clinical phase. So in the 16 months, they get a total of 5 days that they can be off rotation, excused off rotation. Most of that is for things like illness or maybe illness of a family member or child they need to take care of, a family emergency, death in the family, something along those lines. Occasionally those students will also have, a family function. Maybe it's a 20-year reunion or a wedding that they are involved in. They'll request off, and we ask that they request that absence off to be approved by me, and then they work with you to determine how they may need to make up that missed time. If they do have an acute illness or emergency, we ask that they notify both you and the program as soon as possible, just so that we're all aware of where they are and what's going on. So for evaluations, I mentioned there's 2, a mid and an end of rotation evaluation. The mid rotation occurs after the 3rd week, so halfway through the rotation. And then these 2 evaluations are exactly the same. They match the learning outcomes in the syllabus. So if you wanted to know what they're going to be evaluated on, it's very clear to both the student and the preceptor what the assessment will be at the end of the rotation. This would be sent to the preceptor via an email, just an email with a link to click. There's not a login password that you need. Simply click on the link, and then what we're looking for is that students meet kind of a competency of achievement or better in all areas of the learning outcomes. It's essentially a Likert scale of 5, so achievement would be a 3. And then there's above achievement and exceptional achievement above that. So any of those things, as long as they're meeting that, that's what we would consider to be competent in that clinical rotations learning outcomes. We, in addition to the end of rotation evaluation that you would complete on them, students are required to submit some documents. So they are required to do patient case logs during every rotation that they upload into a certain database that we use. They will complete an evaluation of you or of the rotation at the very end. And then they'll have an end of rotation exam to complete specific to that rotation they just finished. There's no exam though for a selective or elective rotation. So what we're looking for is all of these things together is what determines if a student is going to pass the rotation or not, and that's dictated by the program. So we're hoping that kind of takes the onus off the preceptor of feeling like they have to indicate the student met all the learning outcomes. We're really looking, again, for competency in these areas. So if you truly feel they did not achieve maybe the ability to do a newborn wellness exam, then we would hope that you put, below achievement or unsatisfactory achievement, so that we would then work with the student individually as a program to make sure they can meet the learning outcome. And that may be through a standardized patient encounter. It may be, something on their elective rotation or selective that we specifically seek out as an opportunity, or even just something where they're meeting with us and doing an assignment. But again, we're evaluating them not only on their rotation as far as passing the rotation, it's all of these measures. So we will be scheduling, when I say we, so Marianne Borgeson is our clinical coordinator for the PA program, and she and I will be scheduling rotations, so the core and the selective rotations for students in spring of next year. And then we will hopefully disseminate that to the students by the end of May or early June. We want them to have opportunities to potentially make housing arrangements or kind of be aware of where they're going over the next year. The scheduling is based on, again, the availability that we get from all of our providers each year. It's a very dynamic process. Student interest, the locations, we have a couple of sites that are outside of Arizona and then other rural locations. So sometimes location or available housing the student may have. Preceptor preferences, if you tell us, I only want students that are highly interested in emergency medicine, coming to me for their emergency medicine core rotation, we're gonna take that into account. And then certainly program needs as well. We have to make sure all students are getting all of these core rotations at some point. Then our elective rotations will be scheduled kind of throughout the year. So we have a full year from the time that we send them out on rotations before they're even starting their first elective. And so it will be based on their interest forms they supply to us. And those will then be kind of scheduled separately. We don't allow for students to request a change in rotation or to swap rotations between themselves. So we'll confirm with you once we have received your availability and we've set our schedule. We'll send out a confirmation saying you have, Nancy Smith and Joe McDonald coming on these dates for these rotation blocks, or however it looks for that year. And if you have any issues, please just let us know, whether that be email or call us. Any rotation scheduling, really, we would like to have occurring with the program. So if a student's on rotation and asking, hey, I really enjoyed this, can I come back and do an elective with you or do my selective? We would just encourage that you kind of redirect the student back to the program and say, happy to, but please talk with your program, have them reach out to me. Our ask of preceptors is kind of that you identify at your site a primary preceptor of record. That way we can kind of have one person in our database that we are scheduling the students under, and provide us with a preceptor site profile form. And then annually we'll send that form back out to you and ask if there's any changes or edits that need to be done. And then just confirming and coordinating with us, again, your capacity for the upcoming clinical year. Students can work with more than one preceptor. So even though there's a primary preceptor of record, if there's other providers within your group that the students will be working with, that's fine. We just kind of, to make things a little bit easier logistically, it'd be nice to have one kind of point person, and somebody that we can schedule under, and then you can kind of determine who they're working with on more the day-to-day basis or week-to-week basis after that. About 4 months before. So if there's different facilities that your department utilizes or that your group utilizes, just letting us know what physical location the PA student will be in, especially in relation to all the other programs that you may be taking students for, or the medical students from Creighton that you may have. We would like to just kind of help figure out and coordinate that with you. And then providing any additional contact information for providers that we may need at the clinical site if they're going to be precepting our students. Again, so Mary Ann and I are the Director of Clinical Education and the PA Clinical Coordinator, so communicating with us if you have any schedule changes or cancellations. Everything should come through the PA program. We really don't have the same clerkship directors or clerkship coordinators that the School of Medicine Medical Education program has. So just communicating directly with us and then being available if we need to, for some reason, schedule a site visit with you or talk with you about student concerns or program concerns. So I have a couple of resources for you. This website is our Preceptor website. We'll be posting these videos there. We will ensure that all primary preceptors receive the rotation syllabus so you can see the learning objectives and outcomes, a copy of the evaluation that you'll be filling out on the student, and then a preceptor handbook that again has those kind of observed holidays and some other just general information, stuff like this that we're going over about the program in there. This is my direct email, phone number, and cell phone, and then Mary Ann's contact information. But I just want to make sure that if there's any questions that we're able to spend a few minutes answering those questions. If you have a question, you want to unmute your mic and just ask, that would be fine. I think some of the other kind of more informational stuff about methods for preceptor teaching, evaluating students, fitting students into a busy clinical schedule. Those are all upcoming in our future series, November and January and March of next year. But if you do want to receive CME for today's session, you can. There's a survey link in the chat that you can utilize and fill that out. And again, this will be posted not only on our Preceptor resources website of the PA program, but I think Jessica will be placing in a couple other places as well.
Carla, could I ask a question?
Yes.
You were going over the requirements for preceptors, and my impression was that this was the university's position on what it required to be a preceptor, as opposed to like a state rule that if you're going to be a preceptor. Is that correct?
Yeah.
Like you had to practice for a year. Okay.
Yeah, this is actually at the program level. So each program has to determine within the standards of our PA accrediting body, we have to then determine kind of what is allowable by the program for being a preceptor. So that's where like the year of experience for PA or NP is required, but that's not by any means a state statute or law.
Okay, thank you. And I'm in pharmacy, but I was interested in this because I deal with students all the time, and it's always good to know what our other programs offer. But yeah, like for certain states in pharmacy, it's a state requirement that they have to, in order to be a preceptor, they have to have been a pharmacist, for example, for a year. So thank you for clarifying. I appreciate it.
Sure, interesting. And I just found out that the state of Arizona is, they have some grant money that they're providing if you are going to precept a PA student and you are a member of the State Association of PAs, so ASAPA here in Arizona. You can apply for, it's $1,000 for 1 year of time, and it can be for a minimum of precepting one student. You have to not be receiving any other monetary compensation from the program. And I think you have to not only be a member of ASAPA, you have to be like a volunteer, which can mean that you're a member on one of their committees, very, minimal time commitment, that kind of thing. But that is something that just passed in our state statute. And so I think that's a great way to, if you want to get involved and you want to recoup some money too, it's a nice chunk of money. Okay, well, I think that's time. I'm gonna let everybody get back to their day and enjoy the rest of their lunch. Thank you for attending. Our next session is the Omaha session, which is, I think, in early November. And then after that, the end of November will be our first kind of preceptor development session. Thank you for attending, Terry.